Hey everyone, welcome and thanks so much for making time for this. I know your schedules are packed, so I really appreciate you being here. My name is Danielle and today we're going a full deep dive into our adult mechanical ventilation procedure and protocols across the ECU health system. Now, before we jump in, let me set the stage for what this session is all about. This is not just a quick refresher or a policy read-through. We're going to walk through every single protocol algorithm step by step, so by the time we are done, you feel confident navigating these workflows at the bedside, you know exactly where to document, and you understand when and how to escalate to the care team. Here's what you can expect over the next 45 minutes to an hour. We're going to start with the big picture, the why behind these updates, using an SBAR framework so you understand the situation, background, assessment, and recommendation driving these changes. Then we'll shift into the actual protocols themselves, and I'll walk you through each algorithm flowchart in detail. We have 5 active system-wide respiratory care protocols that we cover: ventilator initiation, spontaneous breathing trial, tracheostomy ventilator weaning, post-op rapid wean, and cardiac surgery rapid wean. For each one, I'm going to explain the decision points, the clinical rationale, and what has changed, and what you need to do differently going forward. A couple of housekeeping notes: if you're watching this as a recording, feel free to pause and rewind. There is a lot of detail here, and I want you to absorb it, not just hear it. If you're in a live session, save your questions and we will have time at the end. All right, let's get started. All right, so we are kicking things off with the SBAR framework, and right here we are on the S, which stands for situation. This is where we can answer the question, what is happening right now and why should we care? Here's the situation. ECU Health is actively aligning our ICU practices, including mechanical ventilation protocols, with the Society of Critical Care Medicine PADIS guidelines. PADIS stands for pain, agitation, sedation, delirium, immobility, and sleep disruption. These guidelines represent the gold standard for ICU care, and they are backed by years of rigorous evidence. So what does that mean for us practically? It means we're updating our ICU policies, our mechanical ventilation protocols, and our documentation practices to reflect current best practice standards. This is not about reinventing the wheel. A lot of what we already do is great, but there are gaps, inconsistencies, and areas where our documentation does not fully capture the excellent care we're actually providing. The alignment piece is really important. We're specifically aligning with the ICU Liberation bundle, which you'll hear referred as the A through F bundle. This is the framework recommended by the Society of Critical Care Medicine, and it gives us structured interdisciplinary approach to liberating patients from the harmful effects of prolonged ICU stays. Things like oversedation, prolonged ventilation, immobility, and delirium. Our goal, the bottom line on this side, is to improve patient outcomes across the entire ICU continuum through evidence-based, standardized care practices. That means every ventilated patient, every ICU, every shift, we are following the same playbook. And that consistency is what drives better outcomes. Let us move on to the background. Now, let us talk about the B in our SBAR, the background. This is where we ground ourselves in the evidence and understand the framework that is driving all of these changes. The ICU Liberation bundle, which used to be called the ABCDEF bundle, is an evidence-based interdisciplinary framework that has been endorsed and promoted by the Society of Critical Care Medicine. This is not something one hospital system just made up. This is decades of critical care research into what actually reduces harm and improves outcomes for ICU patients. The framework focuses on several key areas that directly impact our ventilated patients. We're going to talk about minimizing harm from mechanical ventilation itself, reducing the negative effects of sedation, combating immobility and its consequences, and preventing and managing delirium. These are all interconnected. A patient who is oversedated stays on the ventilator longer, does not mobilize, develops delirium, and their outcomes suffer across the board. What makes the ICU Liberation bundle powerful is that it's not just a checklist. It's a coordinated, interdisciplinary approach. Respiratory therapy, nurses, physicians, physical therapy, pharmacists, we all have a role. And when we work together using this framework, the evidence shows dramatic improvements in patient outcomes. And here's the strategic alignment piece that matters for our organization. These outcomes directly align with our patient safety priorities and our regulatory expectations and our quality improvement goals. So this is not just good clinical practice. It is about what regulators, accreditors, and our own quality teams expect to see. The ICU Liberation Bundle gives us a structure to deliver that care consistently and to document it in a way that is visible and defensible. All right, team. Now, I want you to really pay attention to this slide because these numbers tell the story of why we are doing this. This is the evidence behind the ICU Liberation Bundle, and the outcomes are significant. Let us walk through the key outcomes. Look at the top row, the statistics on this slide. First, a 15% higher chance of both survival and being delirium and coma-free for each 10% increase in bundle compliance. Let that sink in. For every 10% improvement in how we consistently follow the bundle, our patients have a 15% better chance of surviving and being free of delirium and coma. That is a direct dose-response relationship between our compliance and patient outcomes. Next, a 15% decrease in the number of days and patients experience delirium in the ICU. Delirium is one of the most significant complications in the ICU. It increases length of stay, increases mortality, and has long-term cognitive effects on patients even after they leave the hospital. Reducing delirium days by 15% is clinically meaningful. Third, an average reduction in ventilator time of 3 days per patient. 3 days. Think about what that means for a patient. Fewer days on the ventilator means less risk of ventilator-associated pneumonia, less sedation, earlier mobility, and faster recovery. For our system, it means better bed utilization and reduced costs. Then we see the 37% fewer ventilator-associated events and 65% fewer infection-related ventilator-associated complications. These are the kinds of numbers that change patient trajectories. Now, look at the lower section of the slide. This is where we break down the actual bundle elements, the A through F. A is assess, prevent, and manage pain, making sure we accurately assess and treat pain so patients are not suffering or being oversedated to compensate. B is both SAT and SBT, spontaneous awakening trials and spontaneous breathing trials, which we will dive deep into shortly. C is choice of analgesia and sedation, setting sedation targets and monitoring to maintain them. D is delirium, assessing risk factors and actively preventing it. E is early mobility and exercise, getting patients moving as safe as possible and soon. And F is family engagement and empowerment, involving families in the care process. These elements are not independent, they work together as a system. And when you perform SAT and lighten sedation that enables the SBT, when the SBT goes well, the patient can mobilize earlier. When they mobilize, delirium decreases. It's a virtuous cycle. And our protocols are being updated to reflect that interconnected approach. All right, let's move on to the assessment. Now we are on the A in our SBAR, the assessment. This is where we take an honest look at where we are today and identify the gaps between our current practices and where we need to be. Let us look at the left of this slide first. Current gaps section. Our current workflows, protocols, and documentation do not consistently reflect the full A through F bundle. That does not mean we are doing bad work. It means our systems and documentation are not set up to clearly demonstrate the interdisciplinary coordination that the bundle requires. Specifically, we have gaps across several areas. Pain and sedation assessment. Are we consistently using validated tools and documenting scores at the right intervals? Spontaneous awake and breathing trials. Are we screening a patient every morning and documenting the why or why not a trial was performed? Delirium prevention and monitoring. Are we using CAM ICU or another validated tool consistently? Or early mobility considerations. Are we documenting mobility assessments and barriers? And family engagement. Are we capturing how we involve families in the care decisions? Now let's look at the opportunity section. This is the exciting part. Updating our policies on ventilation protocols gives us a chance to do several things. We can align better sedation, ventilation, and weaning practices so they work together instead of in silos. We can improve delirium prevention strategies by building them into our daily workflow, and we can support mobility and liberation from mechanical ventilation through coordinated care. And perhaps most importantly, we can clearly show what we do every day in a way that is visible, consistent, and defensible. That last point is key. Many of you are already doing great work at the bedside, but if it's not documented in a consistent, standardized way, it is invisible to everyone else. The providers, the quality team, the regulatory people. These updates help make your excellent care visible. All right, we have reached the R in our SBAR, the recommendation. This is where we lay out what we are actually going to do about everything we just discussed. We're going to move forward with 3 major initiatives. First, policy and mechanical ventilation protocol updates aligned to the ICU Liberation A through F framework. This is the core of what we're going to spend the rest of this session on. Every protocol algorithm you're going to see has been reviewed and updated to reflect our current evidence and PADIS guidelines. Second, documentation changes that better capture interdisciplinary ICU care. This means updates to the electronic health record workflows, new documentation rows and fields, and standardized way to capture things like SPT screening results, failure criteria, and weaning progression. I'll show you exactly what these look like as we go through each protocol. Third, ongoing collaboration across RT, nursing, provider, other therapies, and ICU leadership teams. This is not just a respiratory therapy project. This is an interdisciplinary initiative. We need to buy in and collaborate from everyone on the care team to make this work. Now, here's the key message I want you to take away from this slide. These changes are not about adding work. Let me say that again because I know that is the first concern everyone has. This is not about adding work to your plate. This is about aligning existing best practices, improving clarity in our workflows, and ensuring our care model reflects current evidence and patient-centered ICU care. Additional education and communication will continue as updates are finalized with other work groups, but today our focus is specifically on our current workflow practices and the protocol algorithms themselves. So let us transition now into the actual protocols. We're going to start with some orientation to how these flowcharts work, and then we're going to dive into each one. All right, before we jump into the actual protocol algorithms, I want to take a minute to orient you to how these flowcharts are laid out, because understanding the visual structure is going to make everything that follows much easier to follow. If you look at this slide, you'll notice some of the boxes in our algorithms have what I call outline boxes. These are supporting guidance boxes that sit outside the main flow of the algorithm. They are not extra rules or additional steps. Think of them as reference notes that connect to specific decision points within the algorithm. When you see an arrow or a line connecting one of these outline boxes to a spot in the main flowchart, it's giving you additional detail you need at that particular step. You'll also notice that different boxes have different colored outlines and borders. These are visual grouping tools designed to help you follow the pathway through the algorithm. For example, boxes with the same outline color belong to the same phase or section in that protocol. This helps your eye keep track where you are in the decision tree, especially when the algorithms get complex with multiple branches. The reason I am pointing this out now is that as we go through the next several slides, I don't want you to try to memorize every single box on the flowchart. Instead, I want you to understand the logic, the decision points, the flow. Ask yourself at each step, what is the patient doing? Do they meet criteria? What is the next safe step? And if you understand the logic, the flowchart becomes a reference tool, not a memory test. So keep that in mind as we move forward. These are tools to help guide your clinical decision making, not walls of text to memorize. All right, let us look at one more orientation example on the next slide. Here's another example of what I just described. On this slide, you can see the visual coding system in action. Take a look at how the boxes are organized and how the outline guidance connects to the main algorithm pathway. Notice the visual elements here. You have your main decision pathway flowing from top to bottom or left to right. Then you have these supporting boxes that branch off to provide specific parameters, criteria, or clinical guidance you need at that particular step. The color coding border styles help you distinguish between these different types of information at glance. As we go through each protocol in the upcoming slides, I want you to focus on 3 things. First, what is the entry point and how does a patient enter this particular protocol pathway? Second, what are the key decision diamonds? These are yes or no branch points where you need to assess the patient and determine which path to follow. And third, what are the endpoints? Where does the algorithm take you? Whether that is extubation, returning to a previous step, or escalating to the provider. I'm going to walk you through each decision point in detail so you will not be left guessing. But having this visual framework in your mind will help everything click into place as we go. Think of it like reading a map. Once you know that blue lines are rivers and red lines are highways, navigating gets a lot easier. All right, with that orientation out of the way, let us get into the meat of it. Up next is an overview of all 5 of our active mechanical ventilation protocols, and then we will dive into each one individually. Okay, team, here's our bird's eye view. Right now, ECU Health has 5 active mechanical ventilation per respiratory care protocols that apply system-wide to our adult patient population. I want to walk you through each one briefly so you can have a full picture before we start diving deep into the algorithms. Look at this slide, follow along with me. Protocol number 1 is our ventilator initiation protocol. This is where everything starts. When a patient is placed on mechanical ventilation, this protocol guides your initial setup, including mode selection, tidal volume, respiratory rate, FiO2, PEEP settings. Think of it as the foundation. If we do not get initiation right, everything downstream becomes harder. The updates we have made to ensure our initial settings better align with the lung protective strategies and the PADIS guidelines from the very start. Protocol 2 is spontaneous breathing trial or SBT protocol. This is the beat in our ABCDEF bundle, both SAT and SBT. This protocol is how we assess whether a patient is ready to come off the ventilator. We're going to be standardizing how when we screen for readiness and how that trial is conducted, and what our pass and fail criteria look like. This is one of the biggest areas where consistent practice makes a measurable difference in reducing ventilator days. Protocol number 3 is ventilator weaning trials protocol, and this one is specifically for our tracheostomy patients who have been on the ventilator more than 14 days. These are our longer term, more complex patients. The weaning trial gives us a structured, progressive pathway to reduce ventilator support over time. It is not a rush, it's about safely liberating patients while monitoring their tolerance at each step. Protocol number 4 is the CVICU Rapid Wean Protocol. This is a faster track designed for cardiac surgery patients who have been on the ventilator for less than 24 hours. These patients typically come out of the operating room intubated, and if they are hemodynamically stable, we can move quickly towards extubation. This protocol standardizes that accelerated pathway. And protocol number 5 is the post-op rapid wean protocol, similar concept to the cardiac surgery version, but this applies to our non-cardiac post-surgical patients who have been ventilated for less than 24 hours. Having a distinct protocol for this population ensures we're not applying a one-size-fits-all approach. The key takeaway here is that these 5 protocols cover a full spectrum of adult ventilated patients from the moment they are intubated all the way through liberation. They work together as a cohesive system. In the next slides, we're going to start with the ventilator initiation protocol and work our way through each one. Let's go. All right, here we go with our first protocol algorithm, the ventilator initiation protocol. Before anything else, remember that a physician needs to place an order for mechanical ventilation per respiratory protocol in order for us to utilize the ventilator management protocol. Without that order, we're not on protocol. So that is always step 1, verify the order is in place. Now, let us walk through this flowchart from the top. The first decision you are making is mode selection. Look at the top of the algorithm where it asks to choose the mode. If the patient has adequate spontaneous effort, you're going to start with pressure support ventilation, or PSV. This is our preferred starting point when the patient can trigger breaths on their own. When you are on pressure support ventilation, you target to adjust the pressure support level to keep the respiratory rate at or below 30 breaths a minute. Usually, when you dial in the right pressure support level to control the rate, the tidal volume will fall into an acceptable range naturally. But as a guide, try to keep the tidal volume in the 6 to 8 milliliters per kilogram of ideal body weight range. Now, if you're using a mode with a set tidal volume like volume control, or a pressure control mode like pressure control, or a dual control mode such as PRVC, your tidal volume target is 6 to 8 mLs per kilogram ideal body weight for most patients. However, this is important. If the patient has ARDS, your target drops to 4 to 6 milliliters per kilogram ideal body weight. This is our lung protective ventilator strategy. Lower tidal volumes in ARDS reduce volume trauma and improve outcomes. If you're using a set rate mode, you may adjust the rate anywhere from 10 to 35 breaths per minute based on the patient's needs. Moving down the algorithm, look at the FiO2 and PEEP settings. Set your FiO2 to keep your SATs above 90%, unless the physician order specifies otherwise. For ARDS patients, your saturation range target is a range of 88 to 95%. We do not need to hyperoxygenate these patients, and permissively hypoxemia within the range is evidence-based. PEEP should be set at or above 5 centimeters of water at baseline. You will also see on the algorithm that you may need to check an ABG as needed. Just remember, you will need to place the order for the ABG in the electronic health record before you draw it. Finally, look at the bottom of this flowchart. If the patient has inadequate oxygenation or ventilation, if you are seeing signs of either, you need to discuss with the provider and recommend any changes that need to take place. And here's an important update I want to highlight. The pH threshold has been updated to 7.30 to reflect the updated guidelines and current literature. This is a change from what some of you may have been using previously, so make a mental note of that. Continuing with the ventilator initiation protocol, we are now looking at the second part of this algorithm, the weaning pathway. This is what happens once you have stabilized the patient and there are no acute oxygenation or ventilation problems. Follow the flowchart down from the assessment. If there are no problems with oxygenation or ventilation, then you proceed to weaning as tolerated. This is where your clinical judgment comes in and where the protocol gives you a clear sequence to follow. First priority is the weaning sequence is FiO2. You want to wean the FiO2 down to 40% before you start touching the PEEP. This order matters. FiO2 first, PEEP second. The reason is that PEEP is doing more mechanical work for the lungs, maintaining alveolar recruitment and functional residual capacity. FiO2 is simply the concentration of oxygen. So we reduce the supplemental oxygen first while maintaining the mechanical support. Next, look at the rate weaning pathway of the flowchart. If the patient is on a set rate mode and they are not breathing above the set rate, meaning they are not triggering any additional breaths beyond what the ventilator is delivering, you need to start decreasing the set rate. Decrease it gradually until you see spontaneous efforts emerging above the set rate. And this is an important qualifier. Make sure the patient is not oversedated or pharmacologically paralyzed. If they are not triggering breaths because of sedation, that is not a ventilatory problem. That is a sedation management issue. Coordinate with nursing and the provider team. Once the patient demonstrates sustained spontaneous breathing above the set rate, it is time to transition to pressure support ventilation. When you make that switch, adjust the pressure support level to keep the respiratory rate below 30 breaths per minute. This is the same target we discussed on the previous slide. And here's the most important transition point at the bottom of this algorithm. Once the patient is successfully transitioned to pressure support ventilation and tolerating it, you may proceed to the SVT algorithm. That is our next protocol, and it's where real liberation process begins. So think of ventilator initiation as getting the patient stabilized and onto pressure support ventilation, and the SVT as the gateway to getting them off the ventilator entirely. Let us head there now. All right, team, now we're getting into one of the most important protocols and one that has some significant workflow updates. This is the Spontaneous Breathing Trial or SBT protocol. Pay close attention here because this involves a change in your daily practice. Let me start with a big headline. All patients on mechanical ventilation will be assessed for SBT safety screen every single morning, with the exception of our chronic home vented patients. This is not optional. It is not whenever you get around to it, it is every morning. If night shift is unable to do it before we change shift report, then day shift completes it. We are one continuum offering respiratory care services. This is one of the most impactful things we can do to reduce ventilator days because it ensures no patient slips through the cracks. Now, look at the flow chart. The process starts with the SBT safety screen. This is where the set criteria that determines whether a patient is even a candidate for an SBT. We will get into the specific criteria in the next slide, but the key point here is the workflow branch after the screen. Follow the decision pathway, and if the patient meets the safety screen criteria and they are on protocol, meaning mechanical ventilation per respiratory protocol order is active, then the next step is to discuss with nursing. This interdisciplinary collaboration is a piece of ICU Liberation bundle in action. You're communicating and coordinating with the bedside nurse to ensure the patient's ready and sedation's been addressed and the time is appropriate. Then you proceed together with the SBT. Now, here's a critical piece I want to emphasize, and it ties directly to the ADF bundle. Coordination between respiratory therapy and nursing. Before you proceed with SBT, you need to review the patient's RASS to confirm they are at the right level. RASS stands for Richmond Agitation Sedation Scale, and it is assessed and documented by nursing as part of their workflow. Our job as RTs is to review the RASS score before we proceed. Here is a specific threshold you need to know. The patient may have a RASS of -2 or better to be eligible for an SBT. That means a RASS of -2, -1, 0, or +1 qualifies. Anything deeper than -2, so a RASS of -3, -4, -5, means the patient is too sedated to participate in a meaningful trial. If the patient has -3 or below, they are not going to be able to participate at all or demonstrate whether they can truly breathe on their own. And the results tell you nothing useful about their readiness for extubation. This is exactly why communicating with nursing before you start that SBT is so important. When you go to the bedside nurse and say, hey, this patient passed the safety screen and I would like to proceed with the SBT, you also need to have the conversation about sedation. You've already reviewed the RASS that nursing documented. Are they -2 or better? If not, has the spontaneous awakening trial been completed or considered to even get them there? Remember, the B in A to F bundle is both SAT and SBT. These are meant to be paired together. Ideally, nursing performs the SAT first, lightens sedation to a RASS of -2 or better, and then you proceed with the SBT once the patient meets the threshold. This coordinated SAT then SBT approach is the most backed intervention in the entire ICU Liberation bundle for reducing ventilator days. So what does this look like practically? You screen the patient in the morning, they meet the safety screen. You pull up the chart, review the most recent RASS that nursing's documented. They walk over to the bedside nurse, have a brief, intentional conversation. Hey, this patient screens positive for SBT today, to the bedside nurse. And I see that this RASS is a -2, so I think we're good to go. Or, I see that this RASS is a -3. Have we done anything to lighten the sedation or maybe a sedation awakening trial yet today? If the RASS was -2 or better, you could have proceeded with the SBT. But if they're at a 3 or deeper, you need to coordinate with nursing on the timing. Maybe that patient needs 30 minutes after a sedation adjustment to get to that -2 threshold. That's fine. The key is that you're not walking in and starting a trial on a patient who's too sedated to participate, because that sets the patient up for failure and wastes everyone's time. Now, here's the other pathway that's equally important. If the patient is off protocol, meaning there is no active mechanical ventilation per respiratory care order, you cannot proceed on your own. You need to discuss with the rounding team to obtain a specific order for SBT. And if the conversation with the provider team, the RAS goal should also be a part of the discussion. Is the sedation plan aligned with the goal of the ventilator liberation? If the patient is sitting at -3 or deeper and there's no plan to lighten to -2 or better, that needs to be addressed before we can have a meaningful trial on the patient. This ensures proper physician oversight on patients who are being managed outside of protocol parameters. The key workflow change here to internalize this is every morning we screen, review the RAS that nursing has documented, and communicate with them about sedation readiness. If on protocol and the RAS is at -2 or better, coordinate and communicate with nursing, and you as the respiratory therapist proceed with SBT. If the RAS is deeper than -2, work with nursing on the timing of the sedation awakening trial and sedation adjustment to get that threshold before completing your spontaneous breathing trial. If the patient is off protocol, get an order from the team and discuss the sedation plan as part of that conversation. No patient should go unscreened, and no SBT happens without confirming the patient is at a RAS of -2 or better, and no trial proceeds without proper coordination or authorization. Screen, review the RAS nursing has documented, confirm -2 or better, communicate, and then trial. Now, let's talk about what happens when a patient does not pass the SBT safety screen, because documentation of that outcome is just as important as documentation of a successful trial. So all patients are going to have a daily SBT safety screen above the invasive ventilation group. So we will fill this out daily. If our SBT safety screen result is a fail, we are going to move forward to the invasive ventilation group in the patient's flow sheet. Within that group, we find the SBT trial row. This is where you will type in "not indicated" to record that the patient was screened but did not meet criteria for SBT today. Now, this is something that makes our life easier because this invasive ventilation group with the SBT row is automatically populated on all of our adult mechanical ventilation patients. So you don't have to go searching for it or add it manually. It's already built within our documentation workflow for every vented patient. So why does this matter so much? Because this documentation creates a visible trail that shows that we are screening every day. When quality teams, regulatory, and our own leadership review our charts, they can see we assess the patient, we apply the criteria, and we made clinical determination. Even if the answer today is not indicated or hemodynamics were unstable, that documentation demonstrates that we are following the bundle and the patient was not overlooked. In the next slides, I will walk you through specific safety screen criteria and show you more of the documentation workflow. Now, let us look at the SBT safety screen criteria in more detail. This slide walks you through the specific parameters you are evaluating every morning for each ventilated patient. Follow the flowchart from the top to the bottom. The safety screen is a systematic assessment. You're looking at several key factors to determine the patient's candidate for SBT today. The criteria include things like the patient's current vent settings, their oxygenation status, and hemodynamic instability. Each criteria is a gate. The patient has to pass through all of them to be eligible for the trial. If they fail any one, the screen result is not indicated and you document accordingly. You still need to document which specific criteria were not met, not just a blanket fail. Now, for the patients who do meet the safety screen criteria, look at where the flowchart takes you. If the patient is on protocol, you're coordinating with the bedside nurse and communicating to proceed with the SBT. If they are off protocol, you're reaching out to the provider team for an order. And one thing I want to emphasize here is the timing. We want to perform this safety screen early in the morning before shift change if possible, so that if the patient is a candidate, we have the best possible window to conduct the SBT before noon. Starting early gives us a time for the trial, time for an assessment after the trial, and time to coordinate extubation if the patient passes. Waiting until the afternoon to screen means we may lose that window and push liberation out another day. And every day on the ventilator is a day we are adding risk for the patient. This shows you exactly how the documentation looks when the safety screen result is failed or not indicated. I want you to get familiar with this view because this is how you may see it in workflow. And what you're seeing here is the documentation appears to nursing and to the physician in the EHR. When you document that the SBT safety screen was failed, the information flows to the rest of the care team. This visibility is crucial for interdisciplinary communication. When the provider rounds on the patient and looks at the chart, they can immediately see respiratory therapy screened the patient this morning and what the result was. Nursing can see it, the charge nurse can see it, everyone on the care team has visibility into the patient's ventilator liberation status of that patient without having to track you down and ask. Take a good look at the layout of this documentation view. Notice that the spontaneous breathing trial row appears within the invasive ventilation group, and this is where that daily screening lives, whether the result was indicated in progress, failed, or passed. The reason we are standardizing the documentation is exactly what we talked about in the SBAR section. We need our care to be visible, consistent, and defensible. This documentation workflow accomplishes all three. It's visible because everyone on the care team can see it. It's consistent because every respiratory therapist across the system is documenting in the same place, the same way. And it's defensible because it creates a clear audit trail for our clinical decision making. Okay, now we're at one of the most clinically important parts of this protocol, actually performing the spontaneous breathing trial. If the patient has passed the safety screen, their RAS is -2 or better, and you have communicated with nursing, it's time to trial. Look at the flow chart. Once all the criteria are met, we proceed with SBT, and the trial duration is 30 to 120 minutes. That's our window. The trial needs to last at least 30 minutes to give us a valid assessment, and we cap it at 120 minutes because beyond that, we're fatiguing the patient without gaining additional useful information. Now pay attention to the two different methods of performing SBTs shown on this slide. This is important because the method you choose depends on the patient's clinical situation. The first method, and the one most of your patients will get, is a low-level pressure support trial. You set the pressure support to 5 and a PEEP to 5, so a 5/5. This gives the patient minimal support, essentially just enough to overcome the resistance of the endotracheal tube, and lets you see how they perform on their own. However, there is a key exception. If the patient requires a higher PEEP due to their body habitus, you keep the PEEP at the current level and only drop the pressure support to 5. So for example, if the patient's physiological condition requires a PEEP of 12, you set them at a pressure support of 5 over a PEEP of 12. For the trial, you're not dropping the PEEP because they genuinely need that level for alveolar recruitment. The second method is a T-piece trial, where the patient is completely off the ventilator and breathing through the endotracheal tube with supplemental oxygen. This method is specifically indicated for patients who are intubated for fluid overload or who have significant positive fluid balance, such as those with chronic renal failure or cardiogenic pulmonary edema. The T-piece trial lets you assess for volume overload that might become apparent when you remove the positive pressure. Now, let me address something that comes up a lot: weaning parameters. If the trial lasts at least 30 minutes, you may perform weaning parameters like a NIF or rapid shallow breathing index if the physician specifically requests them, but they are not required per our protocol. And here is the clinical rationale as to why. The evidence consistently shows that traditional weaning parameters are poor predictors of extubation success or failure. A landmark randomized controlled trial by Tanios and colleagues, published in Critical Care Medicine in 2006, studied over 300 patients and found that incorporating the RSBI, the frequency to tidal volume ratio, into a weaning protocol did not improve outcomes. Patients who were weaned without using the RSBI as a decision point did just as well as those who hadn't measured. A 2022 systematic review and meta-analysis published in CHEST, which is one of the largest analyses on this topic, looked at 48 studies involving nearly 11,000 patients. They found that RSBI had moderate sensitivity but poor specificity for predicting extubation success. In plain language, these parameters are decent at telling you a patient might fail, but they're not reliable at confirming a patient will succeed. And more importantly, 2 separate systematic reviews concluded that weaning parameters do not meaningfully change extubation outcomes. Whether you measure them or not, the patient's actual performance during the SBT is what matters. Similar, NIF, or negative inspiratory force, has been shown to be an unreliable standalone predictor. A study by Coe and colleagues in neurocritical care found that none of the individual weaning parameters, including NIF and RSBI, predicted extubation failure. No single parameter and no combination of parameters accurately predicted who would fail. So what does predict extubation success? The SBT itself. The patient's real-time performance during the 30 to 120 minutes of minimal support is the best assessment we have. That is why the SBT is the cornerstone of our protocol, not the parameters. The parameters emerged in the late 70s as an attempt to predict weaning readiness, but decades of research have shown us that they are poor positive predictors. The SBT replaced the approach with a direct functional assessment of the patient's ability to breathe independently. Bottom line, if a physician requests parameters, absolutely perform them. But our protocol does not require them because the evidence does not support their routine use as a gatekeeping step before extubation. The SBT is the test. Trust the trial, and our goal is to complete the SBT before noon whenever possible. That gives us the best chance to extubate the patient during daylight hours when the full care team is available. Now, let us talk about what it looks like when an SBT is not going well. This slide covers the SBT failure criteria, and these are the red flags that tell you to stop the trial and return the patient to full ventilatory support or back to prior support. Look at the failure criteria listed on the flowchart. There are several key indicators you are monitoring throughout this trial period. First and most critical is apnea. If the patient becomes apneic during the trial, this is an immediate stop. We have backup rates, and here is an important safety point. All patients should have that backup rate on the mechanical ventilator during the SBT. Even during a pressure support trial, 5/5, make sure there's an apnea backup rate programmed. This protects the patient if they suddenly stop breathing. For the other criteria, we use a persistent threshold. You will stop the trial if any of the following persists for more than 5 minutes. A respiratory rate greater than 35 breaths per minute, a saturation less than 88%, hemodynamic instability, or an acute change in mental status. The 5-minute qualifier is important. A brief spike in respiratory rate or transient desaturation does not necessarily mean failure. But if it persists beyond 5 minutes, that's telling you the patient cannot sustain independent breathing on their own right now. Let me break each one down. A respiratory rate above 35 for more than 5 minutes suggests the patient is working too hard and is likely heading toward fatigue. A saturation below 88 for more than 5 minutes means the patient cannot maintain adequate oxygenation without support. Hemodynamic instability could manifest as significant tachycardia, hypotension, hypertension, or new arrhythmias. It means the cardiopulmonary system is stressed beyond what it can handle. And an acute change in mental status, whether it's agitation, confusion, or even a decrease, tells you the patient's brain is not getting what it needs. When you identify failure, return the patient to previous comfortable ventilator settings, not just back to the pre-trial settings, but to settings when the patient can actually rest comfortably. Document the failure, which we'll cover on the next slide, and communicate with the care team on the outcome. Documentation of SBT failure. This is a step you cannot skip. When a patient fails an SBT, we're required to document the failure criteria in the electronic health record. Look at this slide. It shows you the documentation workflow for recording SBT failure for adults. You need to capture the specific reason or the reasons the trial was stopped. Was it apnea, sustained tachypnea, desaturation, hemodynamic instability, a mental status change, or was it a combination? All of that needs to be documented. This documentation serves several purposes. First, it communicates the entire care team why the patient failed today and what specific issues need to be addressed before the next trial attempt. If the patient failed because of tachypnea, maybe we need to optimize their pain management or address anxiety. If they failed because desaturation, maybe there's an oxygenation issue that needs to be worked up. The failure documentation becomes a clinical roadmap for what can be fixed before the next attempt. Second, it creates a longitudinal record. When you screen the patient again tomorrow morning, you can look back and see what happened yesterday. Is the patient trending in the right direction? Are they failing for the same reason or a different one? This pattern recognition helps guide clinical decision making. Third, and this ties back to our ICU Liberation bundle goals, It creates the documentation trail that shows we are consistently and systematically attempting liberation. Even failures demonstrate that we are doing the right thing, screening and trialing patients daily. A chart with documented daily SBT attempts that show gradual improvement tells a much better story than a chart with no SBT documentation for days at a time. Make this part of your habit. Trial, assess, document the outcome, whether it is a pass or a fail, and communicate with the team. Continuing with the SBT protocol, let us look at what happens after a patient completes the SBT. This is part of the algorithm addresses the next clinical decisions you need to make based on the trial outcome. If the patient has passed the SBT, meaning they tolerated the 30 to 120 minutes of minimal support without meeting any of the failure criteria we just discussed, the next step is to assess for extubation readiness. Passing the SBT is a major milestone, but it is not the only factor. The extubation decision. Extubation readiness involves a broader clinical picture. Can the patient protect their airway? Do they have a strong cough? Can they manage their secretions? Is their mental status appropriate? Are there any anticipated procedures or surgeries that could require them to remain intubated? These are the kind of questions the care team needs to answer all together. When the patient meets extubation criteria, coordinate with the provider to obtain an extubation order if one is not already in place. For patients on protocol, this may be a part of the standing orders, but always verify. You want to make sure everything is lined up before you pull that tube, including having the appropriate post-extubation support ready, whether that is high-flow nasal cannula, BiPAP, or simple supplemental oxygen. If the patient passed the SBT but is not quite ready for extubation for other clinical reasons, document that as well. The team needs to know that the patient passed the breathing trial but is being held for a specific reason. That way the issue can be addressed and the extubation can happen as soon as safely possible. The bottom line, passing an SBT should create momentum toward extubation. Every hour a patient stays intubated after passing an SBT is an hour of unnecessary risk unless there is a documented clinical reason to wait. On this slide, we're looking at the SBT algorithm pathways for patients who need to be reevaluated or require a different approach after their initial trial attempt. Let us follow the flowchart. For patients who failed their SBT, the algorithm does not just say try again tomorrow and leave it that way. There's a structured approach to what happens next. First, return the patient to comfortable ventilator settings, make sure they're resting, not working hard, and that their oxygenation and ventilation are back to baseline. Then comes the critical thinking piece. Why did the patient fail? This is where you put the clinical reasoning hat on and work with the care team. Was it a sedation issue? Maybe the SAT was not completed before the SBT, and the patient was too drowsy or too agitated. Was it secretion management issue? Maybe suctioning before the next trial would help. Was it a fluid balance issue? Maybe the patient needs more diuresis before the next attempt. Was it pain? Was it delirium? Was it deconditioning from immobility? Each one of these root causes have a different intervention, and addressing the right one increases the chance of success on the next attempt. This is the interdisciplinary piece again. Respiratory therapy identifies the failure, nursing addresses sedation and pain, pharmacy adjusts medications, physical therapy works on mobility, and the provider coordinates the overall plan. The patient should be rescreened the next morning per our standard daily screening protocol. In some cases, if the issue that caused the failure is resolved quickly, the provider may request a SBT the same day. That's fine, but it needs to be ordered. Remember, our goal is not to just perform SBTs. Our goal is to liberate patients from the ventilator as safely and efficiently as possible. Every failed SBT should trigger a problem-solving conversation, not just a notation in the chart. Let us wrap up this SBT protocol section with some key points about the overall workflow and how this all fits together in our daily practice. Think about what your morning should look like with these protocol updates. You arrive on shift, review your ventilated patients. For each one, you ask, is this patient a candidate for SBT? You run through the safety screen criteria. If yes, in their own protocol, you coordinate with nursing and proceed. If off protocol, you communicate with the routed team for an order. If no, and you document not indicated and the specific reasons. For patients who proceed with the SBT, you monitor them throughout the 30 to 120 minute trial. If they fail, you document the failure criteria and return them to comfortable settings and communicate with the team about what can be done differently. If they pass, You move toward extubation readiness assessment and coordinate with the provider. The beauty of the standardized approach, it removes inconsistency. You don't have to wonder whether you should trial today. The protocol tells you to screen every morning. You don't have to guess at what constitutes failure. The criteria are clearly defined. You don't have to figure out where to document. The workflow is built into the electronic health record. And as we transition to the next protocol section, I want you to carry this mindset forward. Screen, trial, document, communicate. That is SVT workflow in 4 words. And when every RT across the system follows the same workflow, our patients benefit from consistent evidence-based care. All right, let us shift gears now towards our tracheostomy ventilator weaning trials. This is a different patient population with a different timeline, so the approach is tailored accordingly. The only difference is if someone has been on a ventilator for less than 14 days that has a trach, you would just continue SBT as tolerated and rest them on the ventilator as needed. Okay, now we're moving on to our third protocol, the tracheostomy ventilator weaning trials protocol. This applies to a very specific patient population, our tracheostomy patients who have been on the ventilator for greater than 14 days. These are our chronic, complex, long-term ventilated patients that need a different approach rather than our acute patients. Look at the flow chart on the side. The standing management for these patients involves several key elements that you are maintaining on an ongoing basis. Pressure support to maintain the respiratory rate below 30. This is your day-to-day ventilator management target. Second, wean FiO2 as tolerated. Just like we discussed in the initiation protocol, we want the FiO2 to get it down as much as the patient will allow. Third, wean PEEP to a physiological level. For most trach patients, this means getting PEEP down to the level that supports oxygenation without overdistension. Fourth, and this is the liberation piece, initiate spontaneous breathing trials. Even though these are long-term ventilated patients, we are still training them for liberation. The approach is just more gradual and progressive compared to our acute patients. Now, here's a special note. For morbidly obese patients, the protocol calls for using passing mirror valve or PMV when conducting SBTs. The passing mirror valve helps direct airflow through the upper airway, which can improve the validity of the trial, the patients by better stimulating what independent breathing will look like after they come off the ventilator. Look at the bottom of the flow chart. At any time during the weaning process, is there a sign of inadequate oxygenation or ventilation? You need to communicate with the provider and make necessary changes. If the situation warrants, you may need to go all the way back to the ventilator initiation flow chart, and that's okay. Patient safety always comes first. Stepping back to stabilize the patient is not a failure, it's good clinical judgment. On the next slide, I'll walk you through a progressive trial schedule and how we build the patient's endurance over time. Now here's where the progressive nature of the tracheostomy weaning protocol really comes to life. This slide shows you the trial progression schedule and its methodical stepwise approach to building the patient's tolerance for independent breathing. Follow the flowchart carefully, assuming oxygenation and ventilation are not an issue, meaning the patient is stable on their current settings. Here's how the trials progress. Initially, you're going to start with short trials, 15 to 30 minutes twice a day, BID. This is conservative by design. These patients have been on the ventilator for more than 2 weeks. Their respiratory muscles have deconditioned. You would not ask someone who's been in a hospital bed for 2 weeks to go run a mile. Similarly, you're starting with a short breathing sprints to build endurance. Here's the progression rule, and it's elegant in its simplicity. Once the patient is tolerating 30-minute trials, you increase the next trial by doubling the last tolerated duration. So if they tolerated 30 minutes, the next trial is 60 minutes. If they tolerate 60, the next is 120, then 240, and so on. You're doubling each time the patient shows they can handle a certain level. This doubling approach is evidence-based, and it gives the patient enough challenge to build endurance without pushing them into failure and fatigue. If at any point the patient does not tolerate a trial, you go back to the last tolerated duration and try again from there. And here is a crucial rest requirement. Always rest the patient overnight on the ventilator. Sleep is when the body recovers and the respiratory muscles repair. You don't want to fatigue a patient all day and then keep them off the ventilator throughout the night. The only exceptions when around-the-clock trials are being attempted, which could be a specific clinical decision made by the provider team for the patients who are very close to complete the ventilator independence. This is a marathon, not a sprint, but with consistent daily trials and progressive increases, these patients can achieve liberation. And here's the finish line for our tracheostomy weaning patients. This slide covers the endpoint of the weaning process and what you do when the patient achieves sustained independence from the ventilator, following the algorithm to its endpoints. Once the patient has been off the ventilator for a full 24 hours, meaning they've demonstrated the ability to breathe independently for an entire day and night cycle, you may discontinue the ventilator per protocol. And here's a practical detail that I want to emphasize. When I say discontinue, I mean discontinue the order and remove the ventilator from the room. It does not need to stay at the bedside. Taking the ventilator out of the room sends a clear message to the patient, the family, and the care team. This patient has graduated from mechanical ventilation, and it also frees up equipment for another patient who may need it. Now, discontinuing the ventilator does not mean we stop monitoring the patient. They still have a tracheostomy. They still need respiratory care. We continue all of those things, such as humidity support, and continue to monitor their respiratory status. The 24-hour independence milestone is also a documentation event. Make sure you document the ventilator discontinuation, the time off the ventilator, and the patient status at the time of discontinuation. This closes the loop on the weaning protocol and creates a clear record of successful liberation. Great job if you're still with me. We have covered 3 of the 5 protocols. Let us move on to the post-op rapid wean protocol. Alright, we are now shifting to a very different population and a very different pace. This is the post-op rapid wean protocol, and as the name suggests, the goal here is accelerated pathway to extubation for post-surgical patients. Let me send the context. This protocol is designed for patients who have already been identified by the physician as a quick wean to extubate. These are the patients who were intubated for a surgical procedure and are expected to come off the ventilator within 24 hours. This is not your chronic ICU patient. They are not your ARDS patient. These are patients who, if all goes well, should be extubated the same day they arrive from the ICU. Now, an important distinction is that although this protocol and the CVICU rapid wean protocol look similar, they are separate algorithms for separate patient populations. The CVICU for cardiac surgery is specifically for cardiac surgery patients, and we'll cover that in the next session. This post-op rapid wean is for non-cardiac post-surgical patients. Follow the flowchart from the top. The first assessment you are making is when the patient arrives to the ICU, whether already spontaneous breathing or not. This is your first branch point and determines the entire initial pathway. If the patient is already breathing spontaneously upon arrival, you're going to place them directly on pressure support ventilation and adjust the settings accordingly. Your targets are the same as the general pressure support management. Keep the respiratory rate below 30, tidal volumes in a reasonable range, and ensure the patient is comfortable. And here's a quick key safety requirement. Stay with the patient for at least 30 minutes after placing them on pressure support. Do not set it and walk away. The initial period is critical for assessing tolerance. Watch for a respiratory rate, the tidal volumes, and the patient's work of breathing, their hemodynamics, and their mental status. If anything is trending in the wrong direction in the first 30 minutes, you might need to be there to intervene. Continuing with the post-op rapid wean protocol, let us reinforce the key points from the previous slide and bridge into the next decision pathway. Remember, this protocol is specifically designed for speed, but speed with safety. The physician has identified this patient as a rapid wean candidate, which means the expectation is what we are moving toward extubation efficiently. But we are not cutting corners. Every step in this algorithm exists because it's the safe way to get the patient off the ventilator. So let us revisit the spontaneous breathing pathway. Patient arrives from the OR, they are triggering breaths, you place them on pressure support, and you stay with the patient for 30 minutes. During those 30 minutes, you're watching for all the signs we've discussed throughout this session. Is the respiratory rate stable and below 30? Is their saturation adequate? Is the patient hemodynamically stable? And are they alert and following commands? If everything looks good at 30 minutes, you're already ready for the next decision point in the algorithm, extubation readiness assessment. For these post-op patients, we're assessing in 30-minute mark. That is significantly faster than our standard SBT protocol because these patients have a fundamentally different clinical trajectory. They are breathing fine before surgery, and we expect them to breathe fine after surgery once the anesthesia wears off. If the patient is not tolerating pressure support during the first 30 minutes, don't force it. This may not be a rapid wean candidate after all. The algorithm has a pathway for that, and we'll cover that on the next slide. The key is to recognize it early when the patient's not following the expected rapid wean trajectory, so you can pivot to the appropriate management strategy. Stay flexible, stay attentive, and let the patient's clinical picture guide you. The protocol gives you a framework, but your assessment skills are what make it work. Now, let us follow down the other pathway on the post-op rapid wean algorithm. This one's for patients who are not spontaneously breathing upon arrival to the ICU and who cannot manage adequate minute ventilation on their own. Look at the flowchart. If the patient is not spontaneously breathing or if they're unable to maintain a minute ventilation more than 5 liters per minute, you're going to set them up on a control or assisted mode with the following settings. a rate of 12, a target tidal volume 6 to 8 milliliters per kilogram, ideal body weight, a PEEP of 5, and a FiO2 initially at 60% to maintain a SpO2 of greater or equal to at least 94%. Notice the SpO2 target here is 94%, which is higher than our standard ICU target of 90%. That is because these are post-surgical patients without underlying lung disease who should be able to maintain higher saturations. If they cannot maintain 94%, that's a sign that something else might be going on. From this starting point, your next goal is to wean pressure support once adequate spontaneous efforts are present. You are looking for the patient to start triggering breaths and maintaining a minute ventilation at least 5 liters per minute on their own. Once you see that, transition them to pressure support. Now, here's an alternate pathway for patients who were placed on pressure support initially because they were spontaneously breathing on their own for arrival. For these patients, look at the algorithm. You assess for extubation readiness at 30 minutes after arrival. Do they meet the safety screen criteria? Both pathways converge towards the same goal: ventilator liberation. What just get there faster than the other, depending on the patient's respiratory status upon arrival. The protocol accommodates both scenarios, and your job is to identify which pathway applies, follow it accordingly. Alright, these are the final steps of the post-op rapid wean protocol. This is whether we liberate the patient or recognize they need more time. Look at the flow chart. If the patient does not meet the criteria at the initial assessment in the algorithm, it's pretty straightforward. Reassess every hour until extubated. You're not waiting until tomorrow. You're not waiting for rounds. You're reassessing hourly because these patients are expected to wean quickly. Every hour you wait is an hour of unnecessary ventilation. Now here is a critical safety valve in the algorithm. If at any time the patient's not a candidate for rapid wean, meaning their clinical status has deteriorated or they are not progressing as expected, you proceed with the standard ventilator management protocol. Do not force a rapid wean on a patient who's not a rapid wean candidate. Recognize when the trajectory has changed and shift to the appropriate protocol. When the patient does meet the criteria, your next step is to notify the physician and obtain an extubation order. These patients will need a specific extubation order. They don't automatically get extubated just because they pass criteria. And here's an important distinction from our SBT protocol. These patients will not need a formal SBT unless the physician specifically requests one. The rapid wean trial itself serves as an assessment of the patient's ability to breathe independently. Let me emphasize that last point because it comes up a lot. Post-op rapid wean patients do not need a separate SBT. The protocol itself incorporates the assessment of spontaneous breathing. If the physician wants a formal SBT on the top of the rapid wean assessment, they'll order it. Otherwise, once the patient meets extubation criteria, get the order and proceed with extubation. Always have your post-extubation plan ready before you pull the tube. Know what supplemental oxygen device you're going to use and have suction available, and be prepared in case the patient needs reintubation. Safety first, as always. Alright team, we're on our 5th and final protocol, the CVICU rapid wean. This is where cardiac surgery rapid wean protocol, and while it shares a lot of similarities to the post-op rapid wean we just covered, there are some important differences specific to cardiac surgery population. First, the biggest difference is the scope. All patients arriving to the cardiac surgery ICU from the operating room will be considered for this algorithm, not just selected patients. Everyone coming out of cardiac surgery is a potential rapid wean candidate unless they come out of the operating room unstable. That is a broader application than the post-op protocol, which requires the physician to specifically identify the patient as a rapid wean candidate. Now, let us look at the initial ventilator settings because this is where you see a clinical difference. Initial tidal volumes for cardiac surgery patients are slightly larger, 8 to 10 milliliters per kilogram of ideal body weight compared to the 6 to 8 in the post-op protocol. The rationale here is that cardiac surgery patients often have atelectasis from the surgical procedure, and slightly larger tidal volumes in the immediate post-operative period help with the lung recruitment. PEEP is still at 5 centimeters of water, same as the post-op protocol. And FiO2 is initially started at 60%, whatever is needed to maintain an SpO2 of 94% or greater, which is the same target. Follow the flow chart after the initial assessment. If the patient arrives to cardiac surgery with spontaneous respiratory efforts, we attempt pressure support first. Adjust the pressure support level to maintain comfortable breathing. However, if the patient cannot maintain a minute volume of at least 5 liters per minute on their own, we place them on SIMV PRVC or APV SIMV with a set rate as a safety net. The expectation is the same as the post-op protocol. Transition to pressure support as soon as the adequate spontaneous efforts are present. And just like before, stay with the patient for the first 30 minutes after placing them on pressure support. These are fresh post-op cardiac patients. Hemodynamic shifts are common, and you need to be at the bedside monitoring for their response and ventilator changes. Let us move forward to the final slide to cover extubation in these patients. Here is the final piece to the puzzle, the extubation pathway for our cardiac surgery rapid wean patients. And there is one very significant difference here compared to the post-op protocol that I need you to pay close attention to. Follow the flow chart. If the patient arrives spontaneously breathing and you place them on pressure support initially, you assess for extubation readiness within 30 minutes, just like the post-op protocol. If the patient was on a set rate mode first and you transition to pressure support, you assess every hour until they meet the criteria. The assessment schedule is the same as what we covered in the post-op rapid wean. Now, here's the big difference. For cardiac surgery rapid wean patients, you don't need to contact the physician or provider to receive the extubation order. Once the patient meets the criteria defined in the protocol, you go ahead and extubate them. And that's the standard protocol-driven extubation authority for cardiac surgery patients on this rapid wean pathway. Let me say that again because it's important. If the patient is on the cardiac surgery rapid wean protocol and they meet all criteria, you have the authority to proceed with extubation without waiting for a separate order from the provider. This is designed to limit delays. I still recommend communicating with your providers via secure chat. In the cardiac surgery population, every hour of unnecessary ventilation increases the risk of complications, and waiting for a provider to come write an order and see the patient when the patient is clearly ready creates unnecessary bottleneck. This is a significant responsibility and a significant trust that has been placed for respiratory therapists on our team. It means your assessment skills and your adherence to the protocol criteria are critical. If the patient meets the criteria, you extubate, and if they don't meet the criteria, you don't. There is no gray area. The criteria are your guardrails. Make sure you document the extubation, the time, patient response, and your post-extubation plan. Have all of your post-extubation supplies ready and supplemental oxygen delivery device, suction, and be prepared to support the patient if they have difficulty immediately after extubation. And that, team, brings us to the end of our protocol deep dive. Let me do a quick recap we covered and why behind these changes through the SBAR framework, the ICU Liberation bundle, and its evidence-based outcomes, and then walk through all 5 protocols in detail. Ventilator initiation, SBT, trach weaning, post-op, and the walkthrough with rapid wean and CVICU rapid wean. The common thread through all of them is screen, trial, document, and communicate. Follow the algorithms, use your clinical judgment at the decision points. Document everything and coordinate with the care team. Thank you for your time and commitment to our patients. If you have questions, reach out to your leadership or the ICU Liberation work groups. We're all in this together. Now, for a couple important logistics before I let you go, this education has been submitted in May 2026 for one non-live North Carolina Respiratory Care Board CEU with adult critical care. You will see the Microsoft Forms link on this slide. Please make sure you complete the form to receive credit on this education. It only takes a couple of minutes, and you have earned it by putting in the time today. As far as next steps and timeline, the updated policy will be going through governance for formal approval. Documentation updates, it is a targeted go live on June 1st. So you have a few weeks to review this material, ask questions, and get comfortable with the workflows before they're officially in place. I would encourage you to watch this recording again, or at least revisit the protocol slides before that go live date so everything is fresh in your mind. If you have questions, as I'm sure many of you will, as you start applying this at the bedside, please reach out, talk to your department leadership, and connect with the ICU Liberation work groups, or come find me directly. There are no bad questions when it comes to patient care. We're building something here that is bigger than any one protocol or any one discipline. We're building a culture of consistent evidence-based interdisciplinary ICU care across the entire ECU health system. And every single one of you is essential in making that happen. Thank you again for your time and your dedication and your commitment to our patients. Now go take great care of people, and I'll see you out there.